Hello, everyone. Welcome to another episode of the Meet the Trialist at the World Stroke Academy. My name is Octavio Pontes. I am editor-in-chief of the World Stroke Academy. And today we are discussing one of the most exciting topics in stroke prevention, the development of anti-factor 11A inhibitors for stroke prevention. And it's my great pleasure to have today with me Professor Mark Sharma, the director of the stroke program at McMaster University, also an expert in the field of stroke prevention. And we'll be discussing a lot of the developments and also the essential components and the basic foundations for the application of these new agents in stroke prevention. Well, Mike, thank you so much for joining us today. Before we dive into the trial data, can you give, for us, our listeners, an overview about what was exactly what factor 11 and 11A, what are their role in the cascade of coagulation, and also why do you think that they are good targets for stroke prevention?
In the coagulation cascade, factor 11 is not involved in the pathway to hemostasis. It's triggered by thrombin, activated, and it makes clots bigger and thicker. And because of the distribution of tissue factor, which is mostly outside the blood vessel, factor 11 plays much more an important role in pathologic thrombi inside the blood vessel than it does in hemostasis. So this concept of decoupling pathologic thrombi from hemostasis makes this a very attractive target for us to study.
Yeah, makes sense, of course. Mike, several phase 2 and 3 studies have now explored the role of factor 11 and 11A inhibitors across different populations, from atrial fibrillation to other stroke etiologies. Could you walk us through what's the state of the art, what evidence we have so far in terms of stroke prevention using these agents?
So, great question. You know, it starts really with the preclinical evidence. In animals, if you do a bleeding time, you make a little nick and see how long it takes for blood to coagulate, bleeding to stop. There's no effect with factor 11A inhibitors on the bleeding time with or without antiplatelets. And the same is true in people. So after this, specifically with regard to stroke, there were phase 2 trials launched to find a dose of factor 11 inhibitors that would work with antiplatelet agents, very similar to what we did in COMPASS, where we saw a significant decrease in the risk of stroke with low-dose rivaroxaban and aspirin. So in the main, there are 2 trials done in stroke populations at phase 2, Pacific stroke and axiomatic SSP, both with small molecule oral inhibitors of activated factor 11. Now, in those trials, both of them treated patients acutely within 48 hours of occurrence, and both of them used a composite endpoint of clinical stroke as well as MRI-defined infarcts. In axiomatic, that outcome was at 90 days, in Pacific at about 6 months. In both trials, the composite endpoint was neutral, but what we saw was a signal for clinical stroke. So in axiomatic, all doses of milvexian, which was the agent there, reduced the occurrence of clinical stroke over placebo, not significantly, but it wasn't powered for that, with the exception of the highest dose, and that was likely anomalous. In Pacific stroke, what we saw was an effect with the highest dose, which is 50 milligrams once a day, on the occurrence of clinical stroke. And as well, we saw a greater effect in patients who had atherosclerosis. Now, the atherosclerosis, interestingly, didn't have to be causative or related to the stroke. It could be elsewhere on the opposite side, in the aortic arch and mild, but that seemed to be a marker for effect. So with those 2 trials, there were doses both of milvexian and of asundexian in Pacific, which we could take forward to phase 3 trials. And there have been 3 phase 3 trials for stroke prevention. There are a couple ongoing right now. The main ones are oceanic stroke with asundexian, Librexia, which is with milvexian. There are as well 2 trials in atrial fibrillation, oceanic AF, which ended early, unfortunately with a lack of efficacy, and Librexia, which is still continuing in the AF population. So all of these, we're looking forward to having results very soon, so we have an idea of the effect of this in preventing a recurrent stroke, and as well the safety.
Okay, so if, in your opinion, if this drug prove effective, where do you see their greatest potential impact in terms of in which population? I mean, atrial fibrillation, atrial thrombotic stroke, ASUS. Do you have what's your expectations about this?
That's a great question. So we would have loved it if Oceanic AF was positive. There, at least for asundexian, we don't have an option with the current dose in atrial fibrillation. Librexia is still ongoing, and perhaps there'll be an effect there as well. But I think the biggest impact is going to be on non-cardioembolic ischemic stroke, which is 3/4 of the spectrum. Of all the stroke subtypes there, the one where we may have a lower effect is in small vessel occlusion. So we think that may be one of the reasons why the MRI endpoint in the phase 2 trials was not significantly affected. Most of those were small, deep subcortical infarcts, and small vessel disease may be less impacted by these agents. But we'll see. I mean, the trials are large and well-powered. Oceanic stroke is 12,300 patients. We'll be presenting baseline data here tomorrow morning, actually. And Librexia stroke, 15,000. So we expect to have a lot of patients in each subtype, so we'll get a good idea of what's going on. But I think the focus right now is on non-cardioembolic ischemic stroke, waiting for the Librexia AF trial.
All right, Mike, thank you so much for the very enlightening conversation. I think sharing these insights, this fascinating new field of stroke prevention. And to our listeners, I'll invite you to follow up with us with this Meet the Trialist series. We're going to have a lot of very interesting conversations with experts in the field of stroke trials. And I invite you also to share the content of the World Stroke Academy with everyone in the field of stroke. Thank you so much.
Thank you.